like to introduce our speaker today, Dr. Jamie Shoup. Dr. Shoup is a pediatric epilepsy neurologist with Norton Children's Neuroscience Institute. He earned his medical degree from the University of Louisville School of Medicine. He stayed at Louisville and completed his residencies in pediatrics and child neurology before completing an additional fellowship in epilepsy. Dr. Shoup specializes in neonatal and pediatric epilepsy and has a particular interest in autism. So Dr. Shoup will be talking to us about clinical implications associated with neurodivergence. So welcome, Dr. Shoup.
Thank you for that introduction, and thank you for having me. So we'll talk about kind of clinical implications of neurodivergence. So I have no relevant financial disclosures. So we'll first start by going over some of our learning objectives today. And so I'd like to start by defining what neurodivergence is. I'll explore various neurodivergent conditions, including autism spectrum disorder, ADHD, developmental delay, intellectual disability, as well as specific learning disorders. We'll discuss the significance of early identification, as well as accurate diagnosis of neurodivergent conditions with tools that are commonly employed for screening. We'll explore the evidence for underlying causes of neurodivergent conditions with a specific emphasis on autism spectrum disorder. We'll review evidence-based approaches to treating neurodivergent individuals, again with a focus on autism spectrum disorder. And these include things like behavioral therapies, medication management, and support strategies tailored to specific neurodivergent conditions. I'll identify ethical challenges and issues while working with neurodivergent individuals that can range from the need for individualized care, cultural competence, and addressing stigma in the clinical settings. So what is neurodivergence? Neurodivergence is actually a medical term, and it's used to describe individuals whose brains developed and or function differently than typical. This results in different strengths as well as struggles when compared to typical. You can see here on the right that various neurodivergent associated conditions do have strengths that go along with it. For instance, patients with autism may be able to concentrate really well on specific things that they're interested in. Or those with ADHD may have more hyperfocus or creativity. And so figuring out where those strengths are can help to kind of bolster them, as well as identifying the struggles so that we can help with intervention. This encompasses multiple different medical conditions with a diversity of underlying etiologies. And while neurodivergence may be associated with specific pathologies, such as a genetic condition, history of cerebral injury, or in utero exposure, an underlying cause is not always readily identifiable, and we call that idiopathic. So what are some neurodivergent associated conditions? This includes things like autism spectrum disorder, ADHD, developmental conditions such as developmental coordination disorder, developmental language disorder. It also includes things like intellectual disability or specific intellectual disorders such as dyslexia, dyscalculia, or dysgraphia. What is autism spectrum disorder? Autism spectrum disorder constitutes two main domains. So the first is deficits in social communication and interactions, and this must be present across multiple contexts. The presence of restricted or repetitive patterns of behavior, interests, and activities constitutes the second portion. There is a wide range of clinical severity and impact on daily functioning that we see with autism spectrum disorder. And we utilize the leveling system in order to express that need for kind of extra help. Level 1 being those who have minimal needs for additional support, and those who are level 3 who have the most significant need for additional support. Epidemiologically, autism is really not that rare. 1 in 36 children are now being estimated to be identified as having autism, according to the most recent CDC Autism and Developmental Disabilities Monitoring Report. There have been increasing rates over the past couple of decades, as you can see on the right. These increasing rates were thought initially to maybe be due to improved screening. However, this with kind of institutionalized screening being present for more than a decade in most locations, we do continue to see increasing rates of autism, and the cause is not fully known. There is a male to female ratio of 3 to 4 to 1 in favor of males having autism. It is noted across all racial, ethnic, and socioeconomic groups, without a discernible difference within these groups. Next is ADHD, or attention deficit hyperactivity disorder. The diagnostic criteria for this includes, for children up to 16 years of age, need to have greater than or equal to 6 symptoms of inattention and/or hyperactivity and impulsivity, which I will go over in the following slides. For those who are 17 years and older with reported symptoms prior to 12 years of age, you only need 5 or greater symptoms of inattention and hyperactivity. The subtype is largely determined by the presence of symptoms within attention versus the hyperactivity, impulsivity domains. What are some signs of hyperactivity and impulsivity? They include things like frequent fidgeting, squirming in the seat, may leave their seat in situations when expected to remain seated. They often run about or climb in inappropriate situations. Older individuals, however, tend not to do this, and they are more likely to just feel kind of restless. They have an inability to play or participate in leisure activities quietly. They're typically on the go or appear to be driven by a motor. They may talk excessively, often blurt out answers to questions before completed. They have trouble waiting their turn and can sometimes interrupt or intrude on others' conversations or games. What are some of the inattentive signs? Well, these include things like failing to give close attention to detail, so making careless mistakes in schoolwork or work otherwise, have trouble holding attention on things or while playing activities, does not seem to listen when spoken to directly, may not follow through on their instructions, they fail to finish schoolwork, chores, or duties in the workplace, particularly in a timely fashion. They may have trouble organizing tasks and activities. They avoid, dislike, or are reluctant to do tasks that require a lot of mental effort over a long period of time. They may lose things that are necessary for tasks, such as paperwork, homework, eyeglasses, and/or mobile telephones, and are easily distracted, forgetful in their daily activities. Some additional criteria for ADHD include that the symptoms must be present for greater than or equal to 6 months. And this tells us that there is a neurodevelopmental process going on that is much more pervasive than just a 6-month period. It must be present in 2 or more environments. So that includes at school, at home, or at work. If things are only or symptoms are only present in one environment, that may speak more towards what the environment is contributing to the symptomatology. It cannot be explained by another condition. So if all of the symptoms seem to relate to an excessive amount of anxiety or oppositional defiant disorder, then we consider it not to be indicative of ADHD. And we also require that the symptoms interfere with functioning or quality of social work or schoolwork. Epidemiologically, ADHD is very common. Most recently was reported to be around 7 million children, or around 11.4% of the US population 3 years to 17 years old. From 2016 to 2022, we've actually seen an increase of an additional 1 million children receiving the ADHD diagnosis. And you can see on the left that there has been a consistent increase in the overall percentage of patients with ADHD since 1997. Boys tend to be more diagnosed than girls, with about 15% of boys being diagnosed compared to 8% of girls. And there are some important ethnic differences that we see. So Black and white individuals, children, are about 12% of the population have this diagnosis, whereas Hispanic and American Indian or Alaskan Native are about 10%. And it drops off to about 6% for Pacific Islander versus 4% of Asian children. Next is developmental delay. Developmental delay speaks to a failure to achieve developmental milestones in domains of gross motor, fine motor, language and speech, social, and self-help/adaptive functioning. Global developmental delay equates to having significant delays in 2 or more of these domains. It should be noted that these delays are evident before 5 years of age. A counterpart to developmental delay is intellectual disability. Intellectual disability is defined as deficits in intellectual functioning, comprising areas of reasoning, problem solving, planning, abstract thought, judgment, and learning, whether that be academic or experience-based. This leads to impairment or deficits with adaptive functioning that can include things like communication, social skills, personal independence, or school or work functioning. The onset of the disability must be present within the developmental period. Otherwise, we think of it as being a different process. The severity based in standardized testing or IQ testing. This ranges from mild, which is typically an IQ of 50 to 70, to profound, which is less than 20. Moderate being 35 to 50 IQ, and severe being 20 to 35. This is in contrast to specific learning disabilities, which is difficulty acquiring or utilizing specific academic skills. This can be seen in individuals with normal or gifted intellectual functioning otherwise, and seems out of proportion to their level of intellectual functioning. Examples of this include things like dyslexia, which is the difficulty in reading, dyscalculia, which is mathematic difficulty, or dysgraphia, which is difficulty with writing. Epidemiologically, the prevalence of intellectual disability or developmental disabilities is around 8.56%, most recently in 2021. There are also 1 million children, which is about 1.65%, who are diagnosed with intellectual disability. In one meta-analysis, developmental dyslexia was found in about 7.1%. As you can see from the graphs on the right, boys tend to be diagnosed more than girls with intellectual disability, of about 2.3% compared to 1.37% of girls. There is a higher percentage of those who are diagnosed with intellectual disability in the adolescent age ranges compared to the younger age ranges. But part of this has to do with just getting that diagnosis on file. Black children who are non-Hispanic are found to have the greatest rate of intellectual disability at around 2.82% compared to Asian, which is around 0.72%. So early recognition is paramount for these children. We do think that early diagnosis and timely implementation of interventions is what leads to better developmental outcomes and consequently improved skill repertoire in later life. The brain is constantly going through developmental changes in early life, and we want to take advantage of that plasticity or the brain's ability to learn in order to kind of improve their adaptive functioning as they get older. So how can we do this? First, neurodivergent associated medical conditions are also often comorbid with one another, meaning ADHD often goes along with other things such as Tourette syndrome, learning disabilities, developmental delays, autism spectrum disorder. You can see on the left that those with ADHD, a lot of patients have co-occurring conditions in this study. So overall, all age ranges, about 77.9% have a co-occurring condition. The most common being a behavioral or conduct problem, followed by anxiety. Learning disabilities are also very high, and almost a third of patients, or over a third of patients. And we can see that autism spectrum disorder constitutes almost 14%, almost 15%. And so it's important to not only think about the condition at hand when dealing with a neurodivergent associated condition, but also screen for other conditions. And how can we do this screening? Well, first, let's talk about the screening for autism. There are multiple ways that we can screen for these, some that are commonly used within practices now. They include things like parent-completed questionnaires. MCHAT is one that a lot of physicians are familiar with, or providers. This is a 20-item questionnaire from 16 to 30 months. Takes about 5 to 10 minutes to complete, and it's about 85% sensitive for identifying autism. In contrast, the social communication questionnaire, which has more items at 40, is typically used for older children, so above 4 years of age, takes about 5 to 10 minutes also, but has much less of a sensitivity, about 34 to 69%. A more sensitive and specific test is the STAT test, or screening tool for autism in children and young toddlers and young children. This is a clinician-directed and interactive screening, but does require special training in order to get it underway. It has 12 items and is from 24 to 35 months. It takes about 20 to 30 minutes, so is more of an intensive screening, but results in a sensitivity of 92%, a specificity of 85%, and a positive predictive value of 86%, negative predictive value of 92%. Emerging mechanisms for screening include things like AI. So Cognoa has a service called Canvas DX, which is an FDA-approved AI-powered tool for 1.5 to 6 years of age to effectively screen for autism spectrum disorder. It utilizes remote and digital solutions to upload videos as well as parent questionnaires. It takes days to generate a report, and that is sent to the provider. The sensitivity of this is pretty good at 98%, with a specificity of around 79%. The positive predictive and negative predictive value is around 81 to 94% and 98 to 95% respectively. As far as ADHD diagnosis tools, we have a couple of screeners, the most common being the Vanderbilt ADHD rating scales. And these include things like parent rating scales and teacher rating scales, so we're able to identify the symptoms in multiple environments. There are also other scales available, like the Child Behavioral Checklist, the Conners rating scales, as well as the ADHD rating scale 4. Developmental screens that are commonly employed are the ASQ, or Ages and Stages Questionnaire, 3rd edition, the Parents Evaluation of Developmental Status, or the PEDS, Parents Evaluation of Developmental Status or Developmental Milestones, PEDS-DM, the Developmental Assessment of Young Children, second edition, or JC2, Early Screening Profiles, ESP, Brigham's Early Childhood Screens, and the First Step Screening Test for Evaluating Preschools. There are also abbreviated profiles such as the Infant Development Inventory and Survey of Well-Being of Young Children. I think given there are multiple screeners available in these regards, it is important to make sure that you're consistent with yours and comfortable with what the screeners that you're utilizing entail, so as to capture best the development of a given child. So transitioning a little bit more to the factors that contribute to neurodivergence. So what causes a person to have these associated medical conditions? Well, they include things like genetics, and we think of genetics as having a large role, particularly in specific types of neurodevelopmental conditions, such as autism. Congenital infections are also an important factor that can contribute to neurodivergence, as well as certain toxins. There have been a growing interest in gut microbiome differences, particularly within the autism community, but as well as other neurodivergent conditions as a whole, as well as maternal autoantibodies and other maternal conditions such as gestational diabetes, preeclampsia, and PCOS. I will say a lot of these kind of factors, I'll go over specifically the evidence for autism, as that's the specific interest of mine. With autism genomics, we know that there's a clear genetic basis. About 3 to 10% have a sibling recurrence rate, which is higher than we would expect for a polygenic case, but less than we would expect for a classic Mendelian inheritance pattern. About 60 to 90% of monozygotic twins show concordance, which means that a portion of monozygotic twins do not show concordance, where one patient has autism and the other doesn't, suggesting there certainly is environmental factors that are contributing. Our current genomic testing, however, does not capture this high rate of genetic implication. And so on CMA, we find that 5 to 14% can find a causative change. In contrast, a whole exome sequence can identify about 8 to 20% of patients who have a genetic change. So what are some mechanisms for these genetic changes? There's monogenetic, polygenetic, somatic mosaicism, and epigenetic changes that we will go over. Monogenic causes of autism account for about 5 to 15%. They include things like MECP2, or classic Rett syndrome, UBE3A, or Angelman syndrome, CACNA1C, or Timothy syndrome, FMR1, or Fragile X syndrome, and TSC1 and 2, or tuberous sclerosis. Autism risk genes, there are around 1,219 candidate genes at this point, which this was as recent as a couple days ago. We find that these genes have enrichment within 3 functional implications. The first being synaptic biology, second being gene expression and regulation of transcriptional factors and chromatin regulators, and the third being kinase or phosphatase activity. Going over some synaptic functioning proteins that are involved with autism are synaptic adhesion molecules such as neurolignin and neurexins, protocadherins or PCH19, cadherins or CDH8, contactins and contactin-associated proteins, CNTN and CNTNAP, synaptic scaffolding proteins such as SHANK or PROSAP, ion channels, which range from sodium channels, SCN1A or 2A, ClCN4, chloride channels, or potassium channels, KCNQ3. Neurotransmitter receptors have also been demonstrated, such as GABAergic ones, GABRA3, for instance, as well as synaptic formation and organization proteins, of which SYNGAP1 is an important one to recognize. We've also found that there are clusters of candidate genes on the chromosomes. Linkage studies showing that there are multiple loci on chromosomes 1p, 3q, 7q, 15q, and 16p. Polygenic causes of autism are also an important consideration. Many genes associated with autism phenotype are what we call pleiotropic, meaning their phenotypic variability comes from a given genotype. Other genes and environmental factors modulate these gene expressions, resulting in a variable phenotypic expression. Some of the mechanisms by which these polygenic mechanisms occur include epistasis and structural variation. What is epistasis? Well, epistasis is a genetic phenomenon where the effect of a gene mutation is dependent on the presence or absence of another mutation or polymorphism in a non-allelic gene, so a modifier. Wise et al. In 2017 demonstrated that using a reverse pathway genetic approach, there was strong evidence for epistasis for ASD and the RAS-MAPK genes, demonstrating a strong enrichment in single nucleotide polymorphisms in ASD-affected individuals. What are structural variants? Well, these are defined as greater than 50 base pairs, and they include things like copy number variants, or insertional or deletions, inversions, or unbalanced translocations. What's the evidence for structural variants in autism? Using a non-Mendelian pattern in pedigrees of parent-child genotypes from autism families, one study demonstrated that structural variant enrichment in ASD risk genes, which was Kainer in 2023. Most are in non-coding genetic spaces. Overrepresentation and expression quantitative trait loci, suggesting that they affect gene regulation, and they are confirmed to overlap with differentially expressed genes in postmortem brain tissue. There are also identified structural variants in the GERK2 and ACMSD gene, or the kynurenine pathway, that associate with nonverbal cases of autism. Now, there are also some important transcriptional regulation genes that have been found with autism. And they include things like MECP2, FMR1, RBFOX1, and CHD2. MECP2 is associated with classic Rett syndrome, and it is a high-confidence syndromic gene that leads to autism. MECP2 is known to affect transcriptional activation, transcriptional repression, and chromatin organization, as well as protein synthesis and neuronal maturation. So we think that these processes all contribute to abnormal neurodevelopmental outcomes. MECP2 significantly increased promoter methylation in autism was found in the male frontal cortexes when compared to controls. And this is independent of having a MECP2 mutation. So we think that this gene is being changed via epigenetic changes or methylation to lead to promoter methylation changes that correlate with reduced protein expression. So while you may not have a specific gene change in MECP2, it may be genetically altered in those with autism, as far as expression is concerned. FMR1 is associated with Fragile X and is caused by a trinucleotide expansion greater than 200. Most common single gene associated with autism. In fact, About 50% of males who have Fragile X syndrome present with autism, and this is in contrast to about 20% of females. It is a high confidence syndromic classification as well. The FMRP functions by mRNA binding protein and is responsible for the localization, stabilization, and translation of approximately 4% of the fetal brain mRNA. Many of the mRNA transcripts of FMRP handles are for synaptic proteins, and this likely underlies how it affects neurodevelopment. Seems to play a critical role in modulating the behavior of several neuronal voltage-gated ion channels, including BK, SLAC, as well as some of the calcium channels, CAV 1.2 and V 2.2. Next is RBFOX1. Multiple studies have identified that variations within this gene lead to autism as well as developmental delay, and this is considered a strong candidate risk gene via Safari. The RBFOX1 protein regulates both splicing and transcriptional networks. And specifically, the cytoplasmic component of this protein regulates the expression of synaptic and autism-related genes. Finally, the CHD2, or chromodomain helicase DNA binding protein, has numerous reports of de novo loss of function variants leading to autism. It is a high confidence syndromic gene as well. Chromodomain helicase protein 2 and SNF2 related helicase ATP binding domains are implicated. This alters gene expression by modification of chromatin structure and alters the access of the transcriptional apparatus to the chromosome DNA template. Next is transitioning to some of the phosphatase and kinase regulation proteins. So many genes that are associated with these functions have been found in people who have autism. These enzymes control diverse cell functions, including cell cycle, growth, differentiation, and this also includes neuronal cells. Genes within this class include PTEN, CDK8, BRSK2, CASK, and CDKL5. Talking about PTEN, deleterious variants within this gene have been identified in patients with autism, specifically those with macrocephaly, in multiple studies, and it has been found to be a high confidence syndromic gene. PTEN acts as a tumor suppressor gene through the action of its phosphatase protein product, involving the regulation of the cell cycle, and prevents cells from growing and dividing too rapidly. When defective, this protein interacts with another protein of a second gene known as TP53 to dampen energy production in neurons, evident by abnormal levels of energy production in the cerebellum and hippocampus. This is a study via Autism Speaks graphic that shows that in their cohort of around 5,152, and then in 2022, 11,000 or more patients, they found that PTEN was the greatest fraction of patients with a genetic cause. Here is a schematic of the kind of synapse as well as the genes that we were talking about. And so several of these genes that I was talking about are here, showing how important they are for the synaptic functioning. And so here is your neurexins and neurolignins, the CASK protein, as well as TSC1. And so a lot of these proteins that are involved have to regulate the functional unit of the neuron or the synapse. Now, next is transitioning to somatic mutations. So somatic mutations are basically gene changes that occur in just a fraction of the cells in the body, and therefore may not show up in a given sample depending on where the genetic sample was obtained. Collections of 5,947 trios with autism by Liam et al. In 2020 found that 7.5% of mutations were identified as postzygotic, meaning after conception. And this means that genetic mutation enrichment within the amygdala was more common. It is currently estimated to account for roughly 3 to 5% of simplex autism cases. But this is maybe an underrepresentation given how little data we have about the different sampling of the genetics within the brain. Another mechanism is through genetics. And so these are helpful changes in gene expression. However, when we look at the DNA sequences, we do not see any changes. And so it has to do with how the genes are being expressed. There are multiple studies that show changes in DNA methylation within various tissues, including the brain, the blood, and animal models for autism spectrum. Going more downstream are proteomics. And so this has garnered a lot of potential for autism-related biomarkers. This includes increases in proteins responsible for synaptic creation, which include things like BDNF and GFAP, which are implicated in autism. BDNF levels have been reported to be elevated. However, when looking at those who are higher functioning and those who have more developmental delay, those with higher levels tend to have milder autism symptoms. And it is thought that the level of the BDNF may lead to less symptoms within autism because it's protective. Also, STOP or MAP6 proteins have also been shown to be significantly reduced in patients with autism. Hewitson in 2021 analyzed 1,100 proteins and identified 9 proteins that were altered in autism boys when compared to normal developing controls. When taken together, they have about a sensitivity of 84%. 5 of these were core proteins: MAPK14, IgD, DERM, EPHB2, and SUPAR. 4 were additional proteins with ROR1, GI24, EIF4H, and ARSB. They're currently not clinically applicable proteomic analysis, but these are in the works of potentially being available in the future. Another important component is metabolomics. And so there have been reports of altered fatty acid profiles in autism cohorts. In one study, all saturated fatty acids were elevated except for propionic acid, and a decrease in most of polyunsaturated fatty acids was also observed. This is theorized to be due to oxidative stress burden, mitochondrial dysfunction, and potential heavy metal exposure, particularly lead. In another study in 2016, children with autism were found to have lower levels of EPA, DHA, and arachidonic acid. They had a higher ratio of N6 to N4 polyunsaturated fatty acids, and this correlated significantly with symptoms. Another metabolomic protein that's been looked at is the COX-2. And it is a major regulator of PGE2 synthesis, as well as implicated in canonical Wnt signaling. The Wnt signaling abnormalities have been demonstrated in many autism-risk genes, including CHD8 and P10. Wong in 2019 demonstrated that COX-2 knockout mice exhibited autism-linked behaviors such as hyperactivity, repetitive behaviors, altered motor strength, and awkward social interactions. You, in 2008, demonstrated a relationship between autism spectrum disorder and a polymorphism in a COX2 gene, PTGS2, in a study of 151 Korean trios. How exactly the COX2 mutations or potentially even polymorphisms modulate the severity of autism needs to be looked at further. There are also additional studies looking at altered levels of heat shock protein, caspases, interferon gamma, and transforming growth factor, B2, in patients with autism spectrum. Another group of metabolomics that is important to consider are mitochondrial dysfunctions. And so about 5% of patients with autism demonstrate mitochondrial dysfunction compared to around 0.01% in the general population, so significantly enriched. A meta-analysis of controlled studies found that autism is more associated with increases in lactic acid, pyruvic acid, carnitine, creatinine kinase, and transaminases as compared to typically developing contemporaneous controls, and indicates that there is an element of mitochondrial dysfunction within autism. Additionally, in mouse models, certain missense mutations, ND6, inserted into the mouse germline was found to induce autism endophenotypes. Here's a list of various studies that show that there is an increase in autism when mitochondrial function is impacted. Now transitioning away from more of the biologics to some of the exposomic aspects of autism. And so environmental exposures, including gut microbiome, toxins, congenital infections, maternal autoimmunity, as well as other maternal conditions, gestational diabetes, preeclampsia, and PCOS. The gut microbiome has been looked at for autism, especially given many of these patients have GI issues. There are reports of higher Clostridium species identified in these patients, particularly those with GI symptoms, although it is not consistent in all patients with autism. Lower relative abundances of Bacteroides and Prevotella have also been found. And in general, there is a lower microbial diversity. Previous studies have demonstrated an increase in serum serotonin in children with autism, and this is thought to be due to gut hypersecretion. Increased tryptophan in the gut is associated with severity of autism symptoms. And the thought is that this tryptophan is not being converted into the indoles that are needed for serotonin, and therefore lead to a less serotonin availability and production in the brain. In another meta-analysis, Clostridium bolte was found to be consistently more abundant in autism children. Bacteroides, stercoides, has been found to be lower relative abundance, and they had high gut microbiome heterogeneity that varied with age and gender. So what does this amount to? Well, so far, supplementation with Lactobacillus reuteri has demonstrated some improvements in autism behaviors, particularly in the mouse models, but more robust human studies still need to be performed. Microbiota transfer therapy has shown preliminary promise in treating GI symptoms as well as autism symptoms, with some reports being seen up to 2 years after the gut transplant. That being said, there are also reports of patients who have gotten the fecal transplant and then are not able to maintain those changes that we see. And so 3 months after getting that transplant, go back to having similar symptoms. So more research is needed to kind of pick out which patients may do best with this therapy. Numerous toxins have been implicated or looked at in autism, as well as other neurodevelopmental or neurodivergent conditions. Air pollution, heavy metals, particularly lead, ethyl alcohol or fetal alcohol syndrome is a well-known cause for neurodevelopmental issues. Certain pesticides, phthalates, BPA or microplastics, chlorinated biphenyls, as well as some medications, the most notably being valproic acid. Finally, certain nutritional factors have been implicated in these conditions, and particularly deficiencies in iron as well as folic acid. A note about vaccination is that numerous studies to date have not found substantial evidence that vaccination leads to an increased risk of development. In fact, in a Danish study of over 600,000 children, of which 6,000 were diagnosed with autism, found no overall increased risk of developing autism given the MMR vaccine versus those who did not get the vaccine. And therefore, it is important to kind of counsel about the use of vaccines, even if the risk of autism is seen in the families. Certain congenital infections are important for autism, and so congenital rubella and CMV have been heavily implicated in the development of autism. As many as 8 to 13% of children with congenital rubella syndrome develop autism from the 1960s rubella endemic. Similarly, children with mothers seropositive for CMV have a statistically significant difference in social responsiveness scores. Those with HSV2 did not demonstrate this difference. And so we think that the immunologic factors and the viral factors for CMV are implicated with ASD pathway formations. Another interesting mechanism is maternal autoantibodies through the work of Judy Vanderwater. And fetal brain is particularly vulnerable to maternal autoantibody exposure, particularly given the variable permissiveness of IgG and the fetal brain barrier. In one study, they found that 11.5% of mothers with autism were found to have this IgG reactivity to fetal brain proteins of 37 and 73 kilodaltons. Multiple studies following replicated similar findings, with rates in 10 to 12%. And this may be an important subpopulation of autism to consider. Antibody patterns of CRMP1 and CRMP2 show the greatest association, with an increase of upwards of 16-fold for autism. Finally, other maternal conditions have been implicated for autism as well, including gestational diabetes, with a odds ratio of 1.42 when compared to ADHD, which did not have an increased odds ratio of around 1.01. Type 2 diabetes, type 1 diabetes also have increased risks, as well as PCOS and preeclampsia, of which the mechanisms are not well understood. So some current challenges is there's a large heterogeneity amongst neurodivergent patients, and therefore we need better study designs with large data sets to garner further associations, especially within subpopulations. Next steps will be getting those large data sets as well as integrating multi-omic data. So genetics, transcriptomics, metabolomics, and proteomics, as well as exposomic data in order to integrate it and get a better understanding for any given individual of what their precision approach should be. Finally, getting into some treatments for neurodivergent conditions. These include non-pharmacologic, pharmacologic, as well as some future directions. Some non-pharmacologic treatments include comprehensive and focused interventions. Comprehensive behavior models include things that are intervention focused at the core symptoms of autism. The purpose is to improve language, cognitive, and functional language skills in young children. They are long-term and intensive and deliver naturalistic environment care, home, school. Can be done individually or in groups and can be delivered by therapists, teachers, or parents. These include things like developmental approaches, behavioral approaches, educational approaches, as well as social relational approaches. Some developmental approaches include things like physical therapy, occupational therapy, speech therapy, early behavioral intervention, and early start Denver model. Some other behavioral approaches include pivotal response training, as well as discrete trial training. As far as educational approaches, TEACH is a good mechanism or a good model to look into. It is the treatment and education of autistic and related communication handicapped children. It's based on the idea that patients with autism thrive on consistency as well as visual learning, and it can provide a way to adjust the classroom structure and improve academic and other outcomes. Some examples of this include daily routines that can be written or drawn in clear, plain sight, boundaries that are set around learning stations, and verbal instructions can be complementary with visual instructions or physical demonstrations. Some social relational approaches include things like floor time, developmental individual differences, and relationship-based models. And this is based on the following interests of the patient to expand on the communication opportunities based off of their interests. Relationship development interventions, activities that increase motivation, interest, and abilities to participate in shared social interactions, social stories, and social skills groups. Some focused interventions can be used as well, and these are supposed to address specific skills or specific developmental domains. They can be provided for typically short durations until that skill is mastered. They include things like toilet training, learner readiness, behavior management, communication training, such as pictorial exchange communication devices, reinforcement systems, as well as executive functioning skills. Some considerations for behavioral interventions include optimal use in early years, so the earlier the better, influenced by social cultural beliefs, and economic capabilities of the family is very important to consider. Plug for ABA, and so this is the only therapy that we have to kind of target the core symptoms of autism. It is evidence-based, and it utilizes positive reinforcement and antecedents, behavior, and consequences. It's adapted to an individual's needs and can be done in multiple settings, as well as one-on-one and in groups. It aims to teach skills important for daily functioning. In one meta-analysis, they found you can expect very effectiveness in improving intellectual abilities, moderate to very effective effects in improving communication skills and expressive receptive language, moderately effective in improving IQ provided by nonverbal tests, adaptive behaviors, and socialization, and the least amount of effectiveness in improving daily living skills. Now transitioning to some pharmacologic treatments. So the most robust pharmacologic agents we have for neurodivergent conditions are ADHD. There are no FDA approved for the core symptoms of autism, developmental delays, intellectual disability, or specific learning disabilities. So non-pharmacologic mechanisms are very important for those groups, but we can treat comorbid symptoms such as attention, hyperactivity, irritability, aggression, repetitive behaviors, self-injurious behaviors, depression, anxiety, and insomnia. This is a list of different ADHD pharmacologic treatments. Stimulants, which can range from methylphenidate, amphetamine, dextroamphetamine, and lisdexamphetamine, as well as alpha-2 agonists, clonidine and guanfacine, which tend to be better for specifically hyperactivity and impulsivity, may not be as helpful for attention. The norepinephrine reuptake inhibitors, or the atomoxetine or viloxazine, and then other medicines that can be considered but are off-label: modafinil, amantadine, disomipramine, venlafaxine, duloxetine, and bupropion. The selection of these different stimulants really depends on their comorbidities. In autism, stimulants can be used, but there are some considerations to keep in mind. Methylphenidate has the most evidence for efficacy and tolerability in autism among the stimulants. There's less evidence for other stimulants, but they are often tried. Compared to patients without autism, efficacy is generally less robust, and they tend to be more sensitive to side effects. Things like headaches, appetite suppression, insomnia, abdominal pain, and irritability are more common in those with autism when using stimulants. The alpha-2 agonists do have a role in autism in that they can be safe, effective for treating specifically hyperactivity and impulsivity, and may also aid in sleep, as is the case with clonidine. Side effects include orthostatic hypotension, sedation, irritability, aggression, constipation, and depression. So the use of these agents should be coupled with what they have comorbid. There is also some evidence for a reduction in repetitive behaviors with the alpha-2 agonists. Atomoxetine has shown through various studies to improve ADHD symptoms in those with autism, as well as inappropriate speech and stereotypic behaviors. However, does not affect social functioning. All right. And then pharmacologic treatments for aggression and irritability include risperidone and aripiprazole. And these are the two FDA-approved options for patients 5 to 16 and 6 to 17 years old, respectively. There are important side effects to consider, including weight gain, drooling, tremors, and sedation, as well as some movement disorder issues such as dystonia or akathisia. Treatment of repetitive behaviors can be accomplished with alpha-2 agonists, aripiprazole, SSRIs, and buspirone. Self-injurious behaviors can be treated with aripiprazole and risperidone, as well as naltrexone can be useful. The treatment of anxiety and depression is common for kids with autism as well as other neurodivergent conditions. There's evidence for low CSF serotonin in patients with autism, so SSRIs are considered a mainstay of treatment. TCAs can be considered but have more side effects, should be used in the context of the given comorbidities. Buspirone may be used, but there's no clear evidence that it's more effective than SSRI and is typically better tolerated. Bupropion can be effective, but should be exercised with care given the increased risk of seizures with those with autism. Insomnia is a major problem for autism, and so numerous pharmacologic agents as well as non-pharmacologic agents can be used. Of the pharmacologic agents, melatonin has been shown to be effective for kids with autism, given they have less levels of melatonin and less sustained levels of melatonin. Consider a time-released version if they're unable to maintain sleep throughout the night. Overall, some general considerations are go slow. They're more sensitive. They need to start typically lower on doses of medicines because they can become dysregulated quite frequently. They have diagnostic overshadowing. So you have to have a high level of suspicion because concurrent communication impairments make it difficult to know exactly what their symptomatology can be. And we must consider side effect profiles and weigh it against their current medical problems. Some novel treatments are in the works for autism as well, including behavioral therapies, brain stimulation, gene therapies, RNA-based therapies, neuropeptides like oxytocin, but there's more to come in that regard. Finally, some ethical issues in neurodivergent population. There's a need for individualized care because they all have unique needs and preferences. So this is not a one-size-fits-all approach. It needs to really take into account an individual's care. And if we have biomarkers available to be able to guide that, such as genetic testing, it is important to consider. But also considering their individualized sensory things, their strengths, their weaknesses, so that we can best tailor their interventions. Understanding that neurodivergent individuals are a part of a diverse cultural background. So we have to be culturally sensitive to that, and that their neurodivergence may be viewed differently depending on that cultural lens. We must address the stigma of these neurodivergences, can lead to discrimination and inequitable treatment. So we must promote awareness of this kind of neurodivergence and be inclusive and respectful. Finally, autonomy and informed consent. We must ensure that neurodivergent individuals are able to make informed decisions for themselves when able and in the context of their own abilities, and constantly evolving our thoughts about how we can best involve them in their care. So in conclusion, I've gone over a lot of things. Neurodivergence is a non-medical term, and it describes individuals who develop or function differently than typical. And it's associated with multiple neurodevelopmental conditions like autism, intellectual disability, developmental delays, ADHD, as well as specific learning disabilities. Early screening and implementation of interventions is essential, and we must optimize these things in order to provide the best developmental outcomes possible. Numerous factors have been implicated in the development of neurodivergent associated conditions. So thinking about genetics, environmental exposures, metabolomics, and evolving our understanding as more research is available. Considering non-pharmacologic and pharmacologic treatments is very important. And going through the individual's needs as well as comorbidities when choosing these agents is important. Remember, start low and go slow whenever using any pharmacologic treatment. And finally, consider all of the ethical aspects of these care, because there's individualized plan need, there's cultural competence interventions, as well as reducing associated stigma and incorporation of autonomy when developmentally appropriate.
All right, thank you, Dr. Shoup. I got a question for you.
Yes, sir.
So someone asks, can you speak more on Fragile X premutation? They say that they have a 9-year-old son.
Yes.
Well, sorry, just a 9-year-old that has autism and ADHD, and a 4-year-old has basically every other neurodivergent problem except for the repetitive portion of autism.
Yeah. We do know that permutation does increase, and it does increase the kind of appearance of certain neurodivergent conditions, and they may have less of a severity within those permutations. And so it depends also on the gender of the child. And so males with permutations tend to have more psychologic symptoms. And so anxiety, depression, ADHD are higher comorbid in those groups. And they may not have the full symptomatology of autism in those cases.
All right. Thank you.